Well, thank you so much, and I'm very sorry I can't be there in person. I've been acutely unwell this morning, and I'm very sorry. Hopefully, next time I can meet you in person. So, I've been asked to talk about sleep in traumatic brain injury, and it's based on work that I've done with colleagues. And I thought I would just give you a rundown of what sleep actually is. So, sleep doesn't mean that we go to bed and die for about 8 hours a day. It's a very active process. And there are different ways of defining sleep, but probably the one that is most useful is that it's a reversible state where we're actually disengaged from and unresponsive to the environment for the most part. And lots of important things happen during sleep, including cleaning our brain, resting our body, pruning our neurons, improving our sort of physiological state, and lots of different hormones are also released during this period. And when you think of someone being asleep, they're usually, but not always, lying down, they're quiet, they're not moving, and they've got their eyes closed. So, what is normal human sleep? So, human sleep isn't just one particular state like wakefulness. We've got two different types of sleep. One of them is called non rapid eye movement sleep, and the other one is rapid eye movement or REM sleep, when we have those crazy, vivid, bizarre dreams that are like B grade movies. And these alternate cyclically over a period of sleep, generally sort of every 90 to 120 minutes. And as adults, we normally get into sleep through our non REM or non dreaming sleep. And we have 4 to 5 dreaming periods in young adults. And this can differ depending on whether, for instance, you're sleep deprived or whether you have a particular disease condition like narcolepsy, etc. So, but this is for someone who has a sort of a normal sleep period. So, how do we measure sleep and how do we investigate sleep disorders? Well, this is a picture of a bedroom in our sleep department, and some of you may have been in our department or in Glasgow or one of the other departments that are dotted around the United Kingdom. And we can this is for the purposes of doing a polysomnography or a major sleep head setup. So we've got wires here that we attach to you. We plug them into this little head box here, and we've got someone monitoring you with the video all night, infrared camera. And this is what we do. So we put some electrodes to pick up brainwave signals, muscle signals, and eye movement signals on the face and on the head. Put bands across the chest and tummy to look at your breathing. We put a microphone on to listen to snoring. And we measure all sorts of other things, including limb movement, oxygen at night. You may have had a clip on your finger to measure your oxygen in the past, your body position, etc. And so we put these in standard positions, and we then pick up those signals over the period of 6 to 8 hours that you're asleep. And we score these page by page. We usually use 30-second pages, so you can imagine what a laborious process that is. And then if we just think perhaps you've got sleep apnea, we will use what we call a limited study or a home study that we can do at home, where we measure your oxygen and airflow. We do measure your, your oxygen with a clip on the finger, and we put a band across your chest and tummy and a position sensor as well. So some of you may have had this done in the past as well. And this is what we end up with. Don't worry, just look at the picture, and basically this is what we end up with to give us information. So up here, we've got what we call the hypnogram. So this gives us the types of sleep. So all the green and the blue are non-REM sleep. And above the line, you can see the dreaming sleep. And most of our deep sleep or slow wave sleep, where our growth hormone is produced during that period and our brain is cleaned, happens in sort of the first half of the night. And then we have more and more dreaming sleep as the night goes on. And you can see that here we've also looked at breathing pauses on a little bar graph. So there's an occasional little breathing pause with these ticks. We've looked at your oxygen, so that's all fine. It's fallen off here, so don't worry. And body position, and this person was quite restless. And that's basically what we end up with. So when we put the wires on your head and we want to actually look at the type of sleep and the different stages of sleep. So this is just a nice way of looking at it for us. And again, if this all looks like wavy lines, don't worry, it is. And we have different brainwave patterns that are generated in the different stages of sleep, which basically help us classify the type of sleep that we're getting. And as we get older, we have a little bit less of our dreaming sleep. You can see this white here from almost half and half when we're born to dreaming sleep, where our eyes move and we have those crazy dreams. And this is the proportion of our non-REM sleep. The slow wave sleep in that non-REM sleep also declines as we get older. How much do we need to sleep? Now, I don't want anyone going home and panicking that they need 7 to 8 hours. It's very much dependent on the person's requirements. And you can see that as newborns, we're basically almost like cats. We're sleeping 18 hours a day. And then our requirements sort of decrease. And of course, this is going to vary depending on whether, for instance, you've had a traumatic brain injury that's affected your sleepiness levels. Also, it very much depends on what age you are and how much of that sleep you require. But you see that as we get older, we need much less sleep than we did when we were born. And it's surprising to a lot of people that even young people right up to the age of about sort of 25 can still need up to 9 hours a night. And that's not abnormal at all. And again, you see that so you can see that 7 to 8 hours is basically just an average. And that's done on huge studies of up to 1 million people at a time. And again, you can see there's a widespread. And there are people who sleep 5 hours a night. There are people who need 9 hours a night, and even up to 10 hours a night. In fact, Albert Einstein needed about 10 hours a night to be fully refreshed. So 7 is just an average. And again, this is from another study which supports that as well. So why do we sleep? So you might ask yourself why we sleep. Well, it's important to remember that sleep is for the brain, by the brain. And basically, the more advanced we are as mammals, the more our cortex or our brain needs to sleep. And when we also know what happens to us from opposite experiments, like what happens when we sleep deprive someone. So you can see that all the different parts of the brain can control different parts of how we think and act. And so if we're sleep deprived, we slow or shut down. And so our frontal lobe at the front, our creative thinking we become less imaginative. We often can't think outside of the box. And this happened in a lot of the 4 nuclear disasters that happened in the 20th century. Sort of people were sleep deprived on night shift at 3 in the morning. And they couldn't think outside the box to fix eminently fixable problems. Prefrontal cortex, that's where we actually make judgments, and we often make very poor judgments if we can't sleep or we're sleep deprived. Language, we can get a little bit more slurred when we talk. Our memory and learning becomes a little bit more affected, and we're not as logical as we should be. This happens when we've done sleep deprivation experiments on people. And the other thing we need to bear in mind that sleep is not just sleep in itself, but we also have, so we've got 2 processes. And this we call the sleep, part of the sleep-wake cycle. And underneath it, we have what we call a circadian rhythm, which means that our wakefulness and sleepiness fluctuate over about a 24-hour cycle. It's about 24.17 hours. Some of us are quicker in cycling and some of us are a bit slower, but it's certainly not exactly 24 hours. And that's why we need things to remind us when it's day and night, things like food, medication, temperatures, and exercise. And then also we have what we call the sleep-wake homeostasis. Don't worry about this term. It just means that the only thing that makes sleepiness go away is sleep. So if you think about it like hunger or eating, the only thing that makes hunger go away is eating something. And that's the same with sleep. So our sleepiness propensity, the fact that we're going to fall asleep, increases the longer we're awake. And these two sort of major processes interact, and they're determined by your genes. So you could be like a natural night owl or a morning lark. And it's also affected by a huge number of other factors, including the environment and our social lives. And this is just a picture just to make it a little bit easier to understand. So this is your sleep process. So over the course, this is 7 in the morning and this is 11 at night. So over the course of the day, we get sleepier and sleepier and sleepier until we're so sleepy that we fall asleep. And then the only thing that makes this go away is sleep itself. And then underneath it, we've got what we call the circadian rhythm, you know, nicely bouncing through the 24 hours. And you can see that we're most likely to feel sleepy when our wake drive is at its lowest and we're at our sleepiest. And we're most likely to wake up and get on with the day when they are at their highest. So I hope that makes sense. So the circadian drive is really regulated a lot by little clocks. We have a master clock inside the brain. And this is it here. So in the pineal gland, we've got in the suprachiasmatic nucleus. This is our master clock. We've also got little clocks, and think of them as little clocks in our liver, in our gut, in a lot of other tissues in the body. And here, as the light goes on, it hits the back of the eye, and the back of the eye sends messages to the biological master clock, and it switches off the melatonin, which is made in the pineal gland. And this is what we call our darkness hormone, which makes us sleepy. And so it's time for us to be awake and alert. And when it becomes darker outside or dimmer, the lights dim, this also is sensed by the back of the eye, and the master clock realizes it's time to get sleepy and go to bed and rest, and that's where melatonin is produced to make us sleepy. So I hope that makes sense to you. So we've got two processes going on at the same time. And I know lots of you have probably heard about melatonin, so it's important to think about it as the darkness hormone and a sleepiness type hormone. So what are the functions of sleep? And this is just a picture to show you that during different stages of sleep, non-dreaming sleep and dreaming sleep, different parts of the brain are active. And you can see that there are lots of parts of the brain throughout the brain which are working to keep us asleep and keep us in particular stages of sleep. So during non-REM sleep, we secrete growth hormone. It's an important stage of our sleep to integrate us emotionally. So if we've had a bad day or we've had a traumatic experience, this is the part of sleep that helps us to work through that. It helps us to clear waste products from the brain, and that's extremely important too. And during dreaming sleep, that dreaming sleep is very important for allowing us to lay down memories and to sort out what is important. And that's maybe where all those crazy dreams come from. And since 2013, 2012, 2013, we know that we have a special clearance, like a lymphatic system within our brain. We didn't know that before this. And this is really, really important also for people with head injury to understand, because this system it clears all the waste products that build up during the day, and it's most active during the night, during slow wave sleep. And that's why sleep is so important. And you can see that this is sort of highlighted in red around the little veins in the brain. And you can see how active this is during slow wave sleep compared to daytime. So that system works 24 hours a day nonstop, but it is most active during our slow wave sleep at night. And this is a sort of an area of research for people who develop neurodegenerative conditions like Alzheimer's, but also is extremely important and should be a focus of research in people with head injury as well in the future. So I'm going to very, very briefly go through what we do know about traumatic brain injury in adults and how we treat it. Now, unfortunately, although we know that traumatic brain injury is incredibly common and much more common than a lot of really major diseases in the world, including breast cancer, HIV, AIDS, etc., very little good research has been done. And you can think of roughly 10 million people every year will experience and suffer from a traumatic brain injury. And I'm really just talking about this in the civilian context. And of course, in the army, in the armed forces, in the police forces, etc., it will be very common as well. And we know that having a traumatic brain injury is not a good thing, and it needs to be treated and appropriately cared for. So I'm not going to go through the assessments because I'm sure you're aware of them. Things like Glasgow Coma Scale, and also doing the imaging is very important, and also the duration of loss of consciousness. So there are a lot of factors that then allow us to classify people as having mild, moderate, and severe traumatic brain injury. And I'm sure that many of you are aware of this and have gone through this. And it's not just the brain injury often, it's also all the other injuries and other issues that occurred at the time of an accident or an injury. And we know that the symptoms that are very important and common include sleep disturbances. And we know that, that there's not only the physical and medical issues, the cognitive issues, and the emotional and behavioral issues, but we know that sleep issues can make all of these a lot worse and also exaggerate them. So you can imagine that if you're sleeping really, really badly, it's going to, affect the way that you think, the way that you respond to pain, the way that you emotionally regulate, how you're responding to daily life, how you're responding to pain, etc. And you can have a, even if you look at some of these symptoms here, and you will know far better than I, if you have suffered a brain injury, how awful these symptoms could be, and then add on top of that poor sleep or disrupted sleep. And this is just a slide to show you that there are lots of inflammatory changes going on in the brain during these periods, that there's a lot of injury going on, and that's why sleep is so important in the throughout the entire sort of progress of looking after someone with a TBI. We know that about 50% of people with traumatic brain injury will have sleep disturbances, and about up to 29% of people will be diagnosed with a sleep disorder. And these include things like insomnia, obstructive sleep apnea, where we snore and have our throat closes over at night to wake us up. People can sometimes become extremely sleepy and have narcolepsy type symptoms. And clearly, if there's a lot of even if there's not much trauma involved, nightmares can be a very disturbing feature. So we also know that people just with traumatic brain injury often just don't have the very efficient sleep that they require. So how do we treat it? Well, it's It's actually not been an area that has been really well studied in terms of good trials of specific treatments. And sometimes the numbers of people that have been looked at have been quite small. And this is then very difficult to generalize to other people with traumatic brain injury. You're probably aware that a lot of the treatment effects that we use in people without traumatic brain injury have then been like plastered or carried over onto someone with a traumatic brain injury. And that's not always appropriate or potentially correct or helpful. But at the moment, that's a lot of the information we have. And I know that many people are treated with sedating medications, which can also contribute to a lot of that fogginess and other issues that people may have. So what sort of treatments have been trialed? And this is based on very, very small numbers of people, all with various degrees of traumatic brain injury. So ones where there's very limited evidence, but people have looked at in trials are acupuncture, warm foot baths, and a treatment that you put through the vein called N-acetylcysteine that was done straight after an injury, and also hyperbaric oxygen therapy. And some of you may have come across this, but none of them have shown any major objective improvements, although blue light therapy seems to have been quite effective in decreasing daytime sleepiness. In terms of insomnia or an inability to initiate or maintain sleep, a couple of studies have trialed melatonin, which they found to be useful, particularly subjectively, using different questionnaires and sleep diaries. And then also a talking treatment called cognitive behavioral therapy for insomnia, which is usually a 6-week course here in the United Kingdom, sometimes an 8-week course in other countries. And although some people found it very effective, there was no objective improvement, but some people found that very useful. And then what about excessive sleepiness? So people who after an head injury become very, very sleepy. And there are a couple of drugs that have been tried. And these are modafinil or armodafinil. And we use these, for instance, in normal sleep practice to treat people with narcolepsy or excessive sleepiness. And again, some of the trials were helpful and some of them were not so helpful, but at least we know it's safe in people with traumatic brain injury. And then you remember how we talked about that circadian rhythm, that sort of underlying sort of 24.17 hour sort of rhythm that most of us have. To try and keep us from becoming extreme night owls or extreme morning larks. There has been one study looking at a melatonin receptor drug, which appeared to be very useful. And then for some strange reason, a medication used in ADHD or narcolepsy and sertraline, which is an antidepressant, were also used. And there was maybe some improvement, but not a huge amount. Again, at least we know it's safe with traumatic brain injury. And then blue light therapy has been very effective. So this is probably, the blue light is sort of a white light that comes out from LED lights, say compared to a campfire where you have mainly red and yellow light. And finally, obstructive sleep apnea is super common in our population overall, and also in people with traumatic brain injury. But again, there hasn't been a really good proper trial, although it was found to be useful in people with traumatic brain injury. And there's been absolutely no good work looking at treatment trials of narcolepsy, people with restless legs disorder, and nightmare disorders after primary traumatic brain injury. And there are studies looking at military personnel, particularly from the VA in the United States, but they're often not particularly well conducted, which is a real shame because there's no need to have poorly conducted trials in this day and age. So rather than going through all of this, I think there's a lot of problems with studies that have been done. I think there's a lot of room for improvement in terms of looking at different treatment strategies in people with brain injury. And also taking into account their physical, mood, and other consequences of TBI that are affecting people's daily life. And so, I think, how could we improve things? Well, I think we need good guidelines, because I haven't been able to find any good guidelines incorporating sleep and circadian rhythm problems in looking after people with traumatic brain injury or in rehabilitation. I think there's a lot of scope for building new trials, and I also think that future research has to sort of incorporate robust methodological approaches with people with all degrees of brain injury in large enough sizes so that we can tell if our treatment or new treatments are useful. And I think it's important for all the disciplines to collaborate. So not just your rehab physician or your neurologist, but people who are psychologists, psychiatrists, and sleep physicians need to be involved, because we've seen, hopefully I've been able to demonstrate to you how important sleep is for the brain. And it's a tremendous opportunity for us to understand how the brain clearance pathways work and how we could maybe modulate them to improve, recovery from injury. And I'll stop it there because I think I've run out of time, so that I can give you an opportunity to ask questions. So thank you so much for your attention, and I'm sorry I couldn't be there today, but I hope this has been at least a little bit useful, and always happy to help. Thank you.